Hello, my name is Lazzarus Santiago, and I get the opportunity to present on the topic of lymphocytic meningitis virus and poliovirus. I like to start with case studies because it helps me to understand the pathophysiology of the organism. I will not read the whole thing. You can pause and read it if you like. I will just give a quick synopsis. Basically, here is a 29-year-old pregnant female hospitalized at 23 weeks gestation because ultrasound showed fetal ascites and minor ventricular megaly. She gets tested for the parvovirus, the torch agents, as well as enterovirus, listeria monocytogenes, mycoplasma, and uroplasma, but everything is negative. So what's going on? Basically, what's going on is the mother transmitted lymphocytic meningitis virus, or LCMV, to the infant. We will talk about that transmission later on, but first let's talk about what is LCMV. It is an arena viridae. Arena means grainy sand because in the electro microgram here we see these particles and it looks like sand. So that's where it gets the name from. And it has a dense lipid envelope with projections of GP1 and GP2. Here we can see it clearly. And the GP2 contains infection mechanism to allow the cell to fuse, the virus to fuse with the cell and to start taking it over. The GP1 is responsible for attaching to the cell. Now, this unit here has an affinity for alpha dystroglycan, which is found in muscle, nerve, heart, and brain. And so we see that LCMV has a strong affinity for neural tissue. And then also, LCMV is a bisegmented, negative sense, single-stranded RNA viruses. So there's two segments, the L segment and the S segment. And they are avisens. And basically what it means is that they're oppositely oriented. And so 3' end will be antisense, which means that you can directly transcribe from this area, whereas the 5' end is positive sense, which means it needs to be copied by the viral RNA-dependent RNA polymerase into a template, and then after that, then it can be transcribed. And so since they're oppositely oriented, something has to tell the polymerase to stop transcribing. And that is in the middle, there's a hairpin, and in that hairpin, there's an intergenic region which signals for the stop of transcription. Transmission. So the reservoirs for LCMV are house mice, which are musculus and mus domesticus. Uh, LCMV can also be seen in hamsters and in rodents in the labs that are being tested with LCMV. Transmission basically occurs through the saliva, urine, feces, and nasal secretions of the mouse. And basically, for majority of part, it's inhaled uh, by us humans. It could also be contracted by touching something that's been infected by the secretion of the mice, and then touching our mucous membrane. That's another way it can be transmitted. And then the last transmission is through a bite from one of these organisms. And so there's two uh, pathogenic cycles that go on. There's the one that MCV is acquired after birth, and there's the quiescence of LCMV before birth. And so right here after birth, when you acquire LMCV, 70% of the cases are going to be asymptomatic or present with mild symptoms. And what I mean by mild symptoms is like a flu-like illness. You know, fever, you feel malaise, you feel weak, but then you just get better. So you didn't even think about this. So 70% of the transmission is asymptomatic or mild. The other 30%, you get a little bit more serious presentation. Since it replicates in the lung, it could cause a parenchymal lung infection. So on chest X-ray, you will see interstitial lung infiltrates and lung edema. And then once it replicates, it will enter the blood and travel to the meninges, choroid plexus, and reticular epidermal linings, which causes aseptic meningitis. And then there's also some uncommon non-neurological symptoms that we see, such as the pancreatitis, orchitis, arthritis, parotitis, and pericarditis. And usually, what happens is that this ends up being a biphasic presentation. And so they'll have fever, headache, malaise, then they'll get better, and then all of a sudden, neurological symptoms like headache, photophobia, vomiting, and nuchal rigidity, something that you will see in meningitis, starts presenting. And so when they get LCMV, transmission as an adult or after birth, this is the typical sequela, and then it goes away. Usually, very rarely does it leave any debilitation or lead to death. Um, for the most part, you get aseptic meningitis and you resolve and you get better, and that's that. There was an epidemiological study in Baltimore that tested the mice, and it saw that 9% of the mice were positive for LCMV, as well as studies show that 5% of Americans have antibodies to LCMV. So the study was done in 2014, and so 5%, 16,551,000 Americans have antibodies to LCMV, which means that they were exposed to it and they developed the antibodies. Probably majority of them not even knowing or thinking it wasn't much because of a minor flu-like sickness. Now, the vertical transmission leads to severe infection. And so vertical transmission is when the mother contracts it, passes it on to the infant. And so this will lead to debilitating features, which we will see in the next slide. But before we get to that, I wanted to talk about the vertical transmission in the mice. And so the mother will, of the mother mice will transmit it to the fetus, but they won't develop a T cell response and they'll just tolerate the virus. And since the virus is not lytic, it will replicate, causing this huge amount of viruses, and then which get secreted in saliva, urine, feces, and which is why it's easy to get because there's such a large amount of the virus in these secretions. Now going back to the infant who gets the LCMV prior to birth, the normal symptoms we see are microencephaly, periventricular calcifications, hydrocephalus, cerebellar hypoplasia, focal cerebral obstruction, gyrodysplasia, visual loss, and chorioretinitis. And once again, this is because the LCMV has a strong affinity for neural tissue and the strong cytotoxic T cell response helps cause these symptoms and this presentation. And they figured this out by studying rats. They injected rats with LCMV, and they saw how the virus interacted within the rats, and they saw that there's a strong neurotropism of LCMV, and then also that they disrupt the migration of the neurons, which led to gyro malformation. And they had a robust cytotoxic T cell reaction, which led to pleocytosis and inflammation, which caused destruction of the cerebral lesions. And so in infants, the most two common symptoms you see for LCMV is hydrocephalus and chorioretinitis. And here we have an image of a normal brain with regular folds, gyri, and reticula. Here is a infant that contracted LCMV prior to birth. And we see the periventricular calcifications here, the ventricular megaly, and ventricular megaly usually is a result of obstructing hydrocephalus or cerebral atrophy. Here we see encephalomalacia, which is softening or loss of brain tissue, and this is a result of that robust T cell uh, uh, reaction that we see from LCMV. And here it's more periventricular calcification. Here's the norm. These are two normal images of the brain, and here pointing to the gyri and the folds of the brain. Here's the cerebella, and this one in infant that contracted LCMV before birth, we see hypoplasia of the cerebella, which leads to floppy muscle tone, developmental or speech delay, problems with walking and balance, seizures, ataxia, mild to moderate disabilities. And here we see a large ventricle and a small brain matter, and this is a result of the virus causing disruption in neural migration. All right, and so the other form of transmission is through organ transplant. There was a study of 3 donors that donated their organs to 10 recipients, and 9 of the 10 recipients died. As far as the donors, 2 of them had no clinical or laboratory signs of infection at the time of donation. The other donor, he had fever and CSF lymphocytosis, but he was negative for HIV, hepatitis B and C, and human T lymphotropic virus, and he met the Organ Procurement Organization criteria for organ donation. So they didn't test for LCMV. They tested for everything else, and since he checked out, he was able to donate. And as a result of these organs infected with the LCMV, uh, 9 recipients died, and the one that survived, he survived. He was given ribavirin and a reduced level of immunosuppressive therapy, which probably allowed them to fight off the virus. Diagnosis. So it is a very underdiagnosed disease because, as we saw before, 70% is either asymptomatic or mild flu-like symptoms, which we wouldn't think twice about. So how do we diagnose it? We isolate the virus from the CSF. And for infants before that contracted before birth, they'll do serological testing such as immunofluorescent antibody testing or enzyme-linked immunoabsorbent testing to test for IgM and IgG to the LCMV. Another method is PCR. Treatment, there's none yet. Ribavirin is under the table medication. It's very toxic, so it's not very popular. But favipiravir shows to be promising. The only problem is that it's only been studied in cell culture, but it has been shown to have a broad antiviral activity against RNA viruses, and it has a robust antiviral activity against arenaviruses. But once again, it was only studied in cell culture and has little toxicity, so maybe in the future this will be a treatment for LCMV. But ultimately, the best treatment is prevention. If you're pregnant, stay away from mice. That is the best prevention for LCMV. Now we're going to take a little break, and here we got a virus doing the. All right, guys, time for the second case study. It is 1954, and about 300 children from the same neighborhood in Chicago enjoyed swimming and other activities at the local YMCA. Over a 3-week period, 17 of these children developed flu-like symptoms with fevers up to 39.5 degrees Celsius, sore throat, myalgias, headaches, and malaise. These symptoms persist for an average of 5 days, after which the victims begin to complain of stiff neck, markedly increased muscle pain, occasional muscle spasms, and elevated fever. These symptoms are followed by flaccid paralysis that varies widely in its degree of severity. Some patients experience paralysis of only a few muscle groups and one leg, for example, while others develop complete paralysis of all four extremities and are totally incapacitated. 4 to 17 victims eventually make full recoveries, but 8 of them recover with varying degrees of residual paralysis. 5 of the victims experienced a continuation of the illness, in which flaccid paralysis of the pharynx, vocal cord, and respiratory muscles develops. These victims are able to breathe only with the help of a mechanical device that provides external respiratory compression. All of them die within the next 6 months. So this is a case study of poliovirus. It is part of the Picornaviridae family enterovirus genus. It is a positive sense single-stranded RNA, and its transmission route is through the intestine, which is why it's part of the enterovirus. There are three strains of poliovirus. There's the Blue Hill, the Mahoney strain for type 1, Lanson and MEFI for type 2, and Leon and Socket for type 3. And basic structure is it has an oxalic acid, which has 60 protomers, with each one consisting of 4 variant proteins arranged in icosahedral symmetry. So here's an image of poliovirus. Transmission is exclusively human. And this is transmitted by the fecal-oral route, basically feces from the person infected with polio, transmits it to the other person orally, uh, and that's how polio gets transmitted. And it's usually a lack of hygiene, or in situation of the case studies, um, they were at a pool, and polio is pretty resistant to chlorine, and so kids that had polio went into the pool, let it go into the pool, and then that's how the other kids were infected. And usually, when it goes into the oropharynx, it multiplies or replicates in the tonsils and lymph nodes of the neck, and then moves on to the Peyer's patches and small intestine. Incubation period could be from 2 to 35 days before symptoms appear, but within 3 to 5 days, you will see polio in the stool, and if you do a throat swab at that time, you will also see polio there. And either it will subside, like the case study said, some kids just had some prodromal symptoms of like flu-like illnesses, or it will spread to the cerebral central nervous system via the bloodstream or the afferent nerve pathway. What's interesting about the afferent nerve pathway is that polio has an affinity for the CD155 receptor, which is abundant in the afferent nerve pathway. And so polio usually attacks the anterior horn of the spinal cord. So there's a cross section of the spinal cord is the anterior horn, the dorsal horn. And when it attacks this area, it causes the flaccid paralysis of the limb. And the reason it does this is because polio has lytic replication. Macrophages will ingest the cells in which the polio is in, which is the axons in the anterior horn, and then it'll just digest it, leading to death of these axons, which leads to the paralysis of the limbs. Now, there's three forms of paralytic poliomyelitis. The spinal poliomyelitis is the one that we see before, destruction of the anterior horn, flaccid paralysis. Bulbar poliomyelitis is the worst because this is where the medulla oblongata gets destroyed. And the medulla oblongata is responsible for respiration. And so these are the kids that have paralysis of the respiratory muscles, and that they needed the iron lung, which was that machine that the case study talked about, in order to help them breathe. And mobile spinal poliomyelitis is a combination of the two. Signs and symptoms: 95% people who get polio are asymptomatic. 4 to 8% are abortive polio, which means they get flu-like sicknesses, might not even think twice about it. Get a little fever, malaise, goes away. Oh, okay, I'm done. 1% are aseptic meningitis. Um, so they start off with the abortive symptoms, the fever, the malaise, and everything, and then um, and then a little bit of recovery, and then they'll get the muscle spasms with the neck, back, and lower limbs, and they'll present with aseptic meningitis, the nuchal rigidity um, symptoms, but then they'll resolve after 10 days. Less than 1% will get the paralytic form. This is excruciating pain at back and lower limbs, and this is usually biphasic. They'll have the mild sickness, the fever-like symptoms, and then they'll improve for 7 to 10 days, and then they'll get hit with the asymmetrical flaccid paralysis of the limbs, and you would notice loss of the deep tendon reflexes, and that's all due to destruction of the anterior horn of the spinal cord. Now, in the case study, we saw that some of the kids had paralysis, but then they recovered. Uh, One sequela of um, polio is that they get the post-polio syndrome 25 to 30 years later after the initial attack, and basically they'll get progressive muscle weakness, joint deterioration, increasing skeletal deformities, and they just won't be able to do anything. They can't do none of their day-to-day living because of this deterioration in the musculoskeletal system. Diagnosis: stool is the most effective, but you want to do it within the first 2 weeks. And the reason why is because it's been shown that 80% of people will have uh, polio in the stool the first 2 weeks, and the number decreases from 80% to 25% by the third week. Uh, you do a throat swab, but only early on while they're showing symptoms, because after that you won't get polio from the swab. Um, Another method that they've been doing is cell culture to identify polio. And if you were to draw blood, you would see that there's a four-fold rise in antibody titer, and this lasts for a life, this antibody. Go backwards. So treatment, early management really was involved. Uh, they really didn't know what to do. They had patients quarantined. Kids were separated from their parents for quarantine to stop the spread. It was a really scary time at that time for poliovirus. I saw a video of 1950, and they had patients in casts, and it was just for long periods of time. And it wasn't until the work of some nurses they realized that heating packs and avoiding these prolonged immobilizations that affected limbs were actually more beneficial. And then it started progressing to a more therapy-like uh, treatment. And so the first rehabilitation center was established in 1926. And then once again, the iron lungs were created for those and had paralysis of the respiratory system to help breathe. And medicine continued to start evolving to include remedial exercises for affected muscles, orthodontics to prevent deformities, secondary to muscle imbalance, physiotherapy, surgeries that include tendon transplant, relieving contractures, and joint replacement. And so the advances in medicine and surgery have really helped to be able to treat polio better. But the number one uh, treatment for polio were the vaccines, the OPV and the IPV. And we saw earlier before that it led to a sharp decline in polio cases. Um, Mothers can transmit the IgG to their children. Children will be protected. And the interesting thing is that 95% of the polio vaccine won't work, but because of herd immunity, those that have the um, poliovirus that was not effective, they're protected by herd immunity. But if a mother does not have antibodies to polio but is protected by herd immunity, she will not pass on those antibodies uh, to the infant because she has none. And so that's why it's important to be vaccinated for polio because every generation will be protected as a result of getting polio vaccine. OPV, the oral form of polio vaccine, uh, is the plan is to do away with that one and to only keep the injectable form of polio because the OPV has been shown to reactivate into active polio and cause vaccine-derived polio myelitis. And so right now, polio is eradicated in most of the world. The only places that has not been eradicated is in Nigeria, Pakistan, and Afghanistan. Uh, and so it's important to get the vaccinations in these places to completely eradicate polio throughout the whole world. These are my references for the topics, and I hope you enjoy my presentation.